in this GCP workshop in last few years also, and now we will be handing over to Dr. Shibsankar Mahato.
Thank you, sir. Myself, Dr. Shibsankar Mahato. Today's my session about informed consent in digital era, trends, ethics, and e-consent innovation in the medicine specialty. It is not working. Basically, there was a poll regarding. It a load.
Tea is ready, so anyone can go and take the tea if possible. Now our next speaker is Dr. Mahato.
So there is a two MCQ, basically a teacher to my session, not working. It is a poll everywhere session, new teaching learning method tool, better than Mentimeter, I think. Question was, what is the main purpose for obtaining informed consent from a patient? So answer, go to the answer, to involve the patient in the healthcare decision. And my next question was, what are the percentage of the doctors who are aware of the informed consent? This is the research of the NTR University 2022, and the shocking result was the 15 to 13% doctors are aware of the informed consent document. So let's start another news. Recently, previous year 2025, Karnataka High Court direct police to lodge FIR against the doctor for medical negligence. There is so many negligence, but one negligence regarding consent. What is the consent? Then patient party consent to operate their patient in a specific surgical OT. But doctor, for their convenience, shifted to another OT complex. Further, usually it happens. The surgical OT may be shifted to trauma care OT center. But court accept the patient allegation that it is a deviation from the consent. The patient party thinks that this OT complex would have better outcome. This is another observation. My session divided in three parts. What is the existing scenario? Then what is the crisis in pen paper? And what is the solution? There is various definition of informed consent from the different point of view, different organization. As per World Medical Association, each participant must be adequately informed of the aims, method, source of funding, any possible conflict of interest, situation evidence from the researcher, anticipated benefit and potential risks of the study, and the discomfort it may entail. And as per WHO observation, on 11 July 2025, consent is the right to say no and boldly the power to say yes. Everyone should have access to information to make healthy decisions about their own lives and the futures. Our very own Supreme Court observation is patients are now widely regarded as the person holding right rather than passive discipline of the care of the medical profession. And as our 2024 Indian Contract Act says that two or more persons are said to consent when they agree upon the same thing in same sense. And our very own ICH E6, as told by Balaram sir, informed consent there is told that a process by which a subject voluntarily confirm his or her willingness to participate in a particular trial after he may inform of all aspects of the trial that are relevant to the subject decision to participate. And then last about informed consent definition, as per ICMR 2017 guideline, the competent individual are entitled to choose freely whether or not to participate in the continue participate in the research, and also says that the information is a continuous process. So there are fewer direct stakeholder, that means potential participant, and where potential participants are somehow defined level, they can engage the law, legally acceptable representative, investigator site, and sponsor. Indirect stakeholder are IEC, Institutional Ethics Committee, and the regulator. Regulator means CDSCO, ICMR, and our IEC bodies. Element of information, there is 4 elements of informed consent: complete informed disclosure, secondly decision making capacity, voluntarism, and authorization. Let's the complete information disclosure. Relevant information to a potential participant is necessary to make an informed decision. This is all described in ICMR 2017 guideline, box number 5.9. I am just copy pasted this session. That is the 10 elements of the informed consent document. First one is statement mentioning that is what is the research. Second is purpose and method, duration, frequency, method, benefit to the participant and community other, foreseeable risks and discomfort and inconvenience, confidential record, payment, rewards of participation, treatment, compensation for injury, freedom to participate, withdraw, identity the research team and contact person. Basically, they are asking about the mobile number or email ID. This is the 10 essential element, and few are not mandatory but optional element. What is the alternative procedure available to that disease? Suppose a liver disease patient, is there any availability of Ayurvedic treatment, homeopathic treatment available or not? What about the insurance coverage? Possible stigmatization condition? What are the preserved material, biological material data and data current or future uses, periodic storage, secondary uses, sharing the data biological material, right to prevent use the biological sample. This is the 10 optional element and 10 element. Basically, informed consent document consists of 2 parts. One is patient information sheet and informed consent form. Patient information sheet, that is detail about the what study is going on, like the template of the patient information sheet, purpose of the research, where will be done, what will be done, etc., etc. ICT must obtain translate into local language for the player understanding. IC must review and approve the ICT before use. Participant must sign in the ICT only after proper explanation and understanding. A copy of signed PIC to be given participant for the record. Next element is decision making capacity. It consists of 4 abilities: understanding the information given by the researcher, appreciation the situation, rationally manipulate the information, communicate the choice. And this decision making capacity depends on cognitivity, ability, and voluntarism. And another word is competency. Competency is a legal notion, a individual legal stake to make healthcare decision. Third is voluntarism, the ability of an individual to judge freely, independently, and in the absence of coercion, what is good or right or best to the subjected to history, his or her own situation, values, and pure history. This is very important that this is own situation, value, and prior history important for the voluntarism. And authorization, this is the last, because this is usually forming the signing document for the informed consent form. The participant must communicate the decision taken voluntarily. Usually this is the form of signing informed consent form with a copy signed to given the participants. So taking consent from a participant, basically diagram will represent if the literate person, then show the PIS and sign in the ICF with date. If he or she illiterate, he can put his or her thumb impression, and he or she may take an LAR for their representative. Representative may sign the ICF document with sign. If LAR is illiterate, then thumb impression also be taken. If there is emergency, no need of consent, as all of you know, then on recovery, consent is necessary. And in case of medical important like dementia or any psychiatric disease, on recovery, consent is necessary. There is age specific because of children less than 18. There is few guidelines. Less than 7 years, there is no need of any kind of opinion from the child less than 7 years. But in case of 7 to 11 years, there is a record of assent. They say the child is a yes, he or she maybe go through the in the form of a head nodding, or yes, you may go with this process. So in the 7 to 11 years, oral assent is necessary. But above that, to 12 to 18 year age, there is written oral assent. That means in this category, there is two ICF, two sign up. One is a child's signature and another is his or his parent or any representative person can the sign. So 12 to 18, there is two ICF is taken. And there is few community consent where like village leader, panchayat and tribal leader provide the community consent because they think that they represent and protect the interest of the communities. Community consent helps build trust and cooperation in research. Then the what is the in this process what are the crises? Analyzing the acute ethical and operational failure of traditional paper-based consent method in clinical environment. In patient side, the dense medical jargon, intense situation anxiety, and small make traditional paper form highly ineffective. Studies reveal that patients rarely read them fully, treating concentrated administrative checkbox rather than actual comprehensive risks. On our side, on researcher part, managing paper consent in modern trial present a severe friction. Common clinical audit observation include outdated form version, retrospective, missing dates, damaged document, illegible handwriting, and emails, archival complex burden. There is a comprehensive guide. As per oncology study, there is all participants sign in the physical consent form. Basically, this patient, so we assume that the patient or participant already know about the what is the burden or what will be the outcome. But 40% of these participants read the original document closely, and more concerned, nearly half of the cohort will recall any single major treatment risk. Suppose a cancer patient taking a chemotherapy drug, they are unable to tell the what is the first or foremost risk factor, what is the EMI or not, unable to tell the first single major risk factor. So digital e-commerce strategy can break this cycle by structuring content digestible segment. What is the digital shift? Future definitely is digital, exploring how technology transforms deficiency compliance into active and patient-centric educational protocol. Interactive e-consent, it is not a scan PDF version. Electronic e-consent is not merely sign on glass. It introduces patient-based module, interactive glossary, multimedia workflow. By empowering patient with highly visual explanation, which is unable to visual in the traditional method, it is easier for them to explainable to them their procedure, their medicine, or etc. Clinician establish deeper therapeutic alliance and meet the superior ethical standard. Role of technology in the digital consent platform, it may be mobile web application that can be accessed anywhere, anytime. Audiovisual material, it enhances the understanding and accessible during the consent process. So, what is the core architecture pillar? Multimedia education, related clinical videos for their study, audio narration, hovering plain language visual definition, dissolve complex terminology. Complex terminology is, if I say posterior part, rather participant better understand the back of the body, not posterior part. Interactive self-quizzes within the workflow build positive cognitive fiction that validate patient understand before signing. And last, immutable digital signature utilizing secure OTP verification, like we all know the e-Hostakshar introduced by NIC, biometric scan, complete electronic audit trail. As already Kishan sir told, digital personal data protection 2020 is demand robot encryption, localized hosting, transparent data processing, and simple withdrawal workflow. Online research consent clearly explain method to maintain participant privacy, data confidentiality, detailed data security measure and protocol in the consent document, outline policy, data usage, sharing, storage, provide researcher contact for participant queries. As per DCGI, mandatory visual recording in clinical trial as per their gadget. Apply especially for the investigation new drug trial. Separate consent required for audiovisual recording. So one consent taken for the participant as a able whether he or she participate or not, and separate consent is required for audiovisual. So there is two consent in this audiovisual platform. One is for the traditional consent, that is whether it goes or not is study, and another separate consent for audiovisual recording. Ensure transparency, participant protection during consent. Confidential is must be addressed within explicit consent. There is study shows the better patient retention rate, participant retention rate, and low dropout in e-consent, regulatory audit error is less, recall or risk understanding is less. So this is the comparison study. Information delivery in traditional paper, monotonous dense text, easily overwhelming. In e-platform, that tired multimedia with interactive explainer. Verification recall in traditional paper, assume just purely physical signature. In digital, verifiable via app interactive. Security auditing, regarding security auditing, vulnerable physical feeling, manual version log. Whether in digital, it is immutable, cryptographically locked digital trial, and in control, there is extreme difficult to execute revision, very hard working. In case of digital, in one click, all information is available to researcher or the participant. So executive review, whether if a researcher is ready to for ethics approval, after getting original, he or she need to deploy a secure cloud portal for the taking the informed consent, and obviously in the local language. Then is onboard patient in clinic. There is comprehensive or related videos explain the whether what study is going on, what will be done, what is the composition, everything in the checkbox in the digital format. And next is cryptographically secure data in India. In India means the data sharing should be must server within India. As per DPT 2023 Act, the server must be within India, not outside the India. Like many Google or something is that not within the Indian jurisdiction. Ethical consideration using public archive, obtaining ethics committee approval alone is insufficient for data usage. Research using online data, library database, archive your permission. It needs the competent authority for consent. Suppose data is stored in MMC's website. So MMC authority person is also necessary. Ensure ethical compliance and respect for data ownership. And this is the traditional right to withdraw. Every participant has right to withdraw from the study at any point without facing penalty or consequence. And continuous consent, researcher must regularly refrain participant understanding willingness toward the study. Where the reconciliation necessary, new study information regarding any drug or disease required to participant to be reconsistent. Participant regaining consciousness or mental competence must be reconscious. Child turning adult more than 18 need to consent. Potential identity disclosure in publication require additional consent. Suppose you publish your study in reputed journal, you putting his or her picture on this journal, so additional consent is again required. Fewer things where waiver of consent can be given by the IEC. Consent may be waived when research on anonymized biological sample data. Certain public health studies, surveillance program may qualify the consent waiver. Researcher using data available in the public domain can proceed without consent. During humanitarian emergency like COVID, consent sometimes must be delayed or later taken, might not be feasible initially. Retrospective study, and last, research regarding medical education, like teaching learning method, research IC can waive the consent. What are the challenging in Indian concept? Because various language in India, around 1,400 language in India, so there is language diversity, cultural sensitivity. Some people resist, some definitely, some disease burden, some in the view, their view is different from the ours, and use of translation also is a barrier. So take home message, mere signature is not consent. The researchers should use only the EC approved version of the consent form, including its local translation. what can we do to improve our informed consent? Simplify our language, allow time for question, make sure the patient understand, plain language, assistance in emergency appointment, train support staff. Thank you. Thank you to all.
Thank you, Dr. Mahato, for very good presentation. And now we will be moving on to our next topic. The next topic is emerging ethical challenges in AI integrated clinical research, and it will be presented by Dr. Abhishek Das. Abhishek Das is Associate Professor in the Department of Forensic Medicine at Jhargram Government Medical College and Hospital, and he has also presented in this workshop in the earlier years. So we will be going for the next presentation. Now, in the meantime, we will be felicitating our previous speaker, Dr. Mahato, Shibsankar Mahato, and he will be felicitated by our HOD and chairman of this workshop, Dr. Professor R.N. Maiti sir. A small memento will be presented to him by